therapies for diabetes and innovative healthcare delivery models for people with diabetes. He played a key role in developing the Solihull integrated diabetes model and chairs the Pan Birmingham Diabetes Network. He also collaborates closely with the Diabetes UK, and he was one of the 12 national clinical champions in 2014. Dr. Bellary has published extensively in prestigious journals like The Lancet, Diabetes Care, Diabetology, and Diabetic Medicine. He is also a senior editorial board member for BMC Endocrine Disorders and the deputy editor-in-chief for the Therapeutic Advance in Endocrinology and Metabolism. Apart from this, though Dr. Bellary stays in UK, his roots are in India. He graduated from Osmania Medical College, Hyderabad, and his interests are he enjoys cricket and badminton and loves to sing Bollywood songs. Dr. Bellary, thank you for joining us today all the way from UK. We know it's still early for you, and we deeply appreciate you taking time to be with us. We are absolutely thrilled to have you to share your expertise, sir. Thank you, sir. The stage is all yours.
Okay. Thank you, Anita. Firstly, I just want to make sure everybody can hear me clearly. Thank you again for a kind introduction. And it's always very immensely a happy occasion to talk to my countrymen. I think it's been about 26 years since I migrated to UK. But I haven't still lost my Indian accent, according to my son. So I still speak Indian accent, and I'm very much Indian in heart. So for the next 35 minutes, I will take you through what's in my opinion, is a epidemic that is emerging and something that's going to have huge consequences globally, particularly if you're managing diabetes. After that, hopefully, we will have some time for questions, and I'm more than happy to interact with you all and take some questions. So if you're able to hear me and see me, then I'll just proceed with my talk.
Sure, sir. Yes, sir. We can hear.
The title of the talk is Type 2 Diabetes in Youth and the Causes and Consequences. Well, the reason we need to be talking about this is we all know that diabetes is now one of the major public health concerns. And I think the last time I saw the figures in India, they were quoted that India has about 100 million people with diabetes. And what we are now witnessing is that not only is type 2 diabetes the commonest form of diabetes becoming more and more common, but it's also impacting younger people, particularly youth. So the definition varies from country to country, but I think conventionally people would say youth would be anybody under the age of 40 years. So what I'm going to talk about is to show you the data around the increasing prevalence and the epidemiology. We will also discuss about the impact it has on lifetime risk of complications and the diagnostic challenges that come with diagnosing type 2 diabetes in earlier age groups. And I will also have some information about the insights into the pathogenesis of type 2 diabetes in youth. So looking at the epidemiology, as I said, we are witnessing a huge increase in the people with type 2 diabetes all over the world. But if you look at more carefully, and this is IDF data, and this is slightly outdated, but I think the same trends are continuing at this present moment, which is there is a very high prevalence in people under the age of 40 years, and that's been persistently growing with time. So if you can look at the bar here, about the green ones are in 2003, and as you can see that the one in pink, which is in 2013, and now this is almost like 10 years old. But you can still see there's a substantial number of people. As in 2013, I think there were about 60 million people below the age of 40. But we also see some patterns emerging, and one of the things is that the Southeast Asia is very severely affected, and so is Western Pacific, and also in major developed countries like the USA, where it's increasing quite rapidly as well. And there's a more recent publication in 2022 looking at the global burden of type 2 diabetes in youth, and they not only looked at the global burden but also looked at the distribution across the different countries, categorizing into the economic status, for example, high and high middle income countries, middle, and low. What we would see here is that, say, this is all below the age of 40 years, and you can see that the prevalence has been increasing in all age groups, whether it is 15 to 19 or, say, 25 to 29 or 35 to 39. And you can see that it's been pretty much very standardly increasing across all of these. In high-income countries, I mean, you could say that the increase is happening, but it's a little bit at a slightly less steep, whereas in the middle income countries and low middle income countries, especially in the last 10 years, there's been a disproportionate increase in the prevalence of type 2 diabetes in younger age groups, and that is a major concern. In the UK as well, we have seen similar trends, and as you can see in this graph here, this is from the General Practice Research Database, and you can see that up to the purple bars, which categorizes are below the age of 40 years. So almost negligible in 1989, but quite substantially increased by the time we had it to 2010. And I think we realize this problem in the UK now, and we've started collecting some more real data on an annual basis. And this was from 2019-20, and in the UK we have now 122,000 people aged under the age of 40 having type 2 diabetes. Now, for a population of UK, that's a sizable number. I must say that only last month they released some more data around this, and this 122 has now gone up to 135 or 136,000. So another 10,000 added just in a span of a year. And from a UK population perspective, again, that is quite significant. So one of the things to remember about epidemiology, and this is something maybe you probably will have to look at it carefully, is that sometimes the modern trends in metabolic diseases, they tend to go in cycles. And we globally, if you look at the patterns, you can see some of the patterns emerging in more developed countries purely because of the sedentary habits, access to, say, high-calorie foods, and so on. So what you would see in some of the highly developed Western countries is something that you would see in, say, countries like India, for example, in the next, say, 10, 15, 20 years. So the epidemiological transition, perhaps India is about 10, 15 years behind, purely because of the sociocultural changes that are happening. So if I'm projecting this trend, what's happening in the UK, you can imagine that this is going to hit India in 15, 20 years, and we need to be prepared for this. It's the same in the aging population. What you are seeing is increased life expectancy and the associated problems we have with aging in Western countries. Now we are already witnessing that in India. So that transition is happening. So in some ways, this is like a forewarning. It gives you a warning as to what is due to come. I tried to look at the data from an Indian context and see what's the prevalence. And there is sporadic data. There isn't a lot of data around prevalence of type 2 diabetes in youth, but I did find some references. One is from Vishwanath Mohan from Chennai and his team, where they have described that from between 2006 and 2016, the prevalence of diabetes in the ages 25 to 34 increased from 5.3% to 10.4%. And that's double in a matter of 10 years. And I don't know what's happened between 2016 and 2023, but I think ICMR must be collecting some data around that, and it'll be interesting to see. There's another publication by Pradeep Kumar and all from BMC Endocrine Disorders just 2 years ago. And again, he describes prevalence of prediabetes, diabetes in adolescents, and this is below 18 years, about 12% pre-diabetes and 8.4% of diabetes, and that's a substantial increase. And there is another publication from Pradeep Pravinial and Nikhil Tandon from Delhi and his team, where they looked at the number of people aged under the age of 25 having different types of diabetes. Now, in that age group, typically we would see type 1 diabetes, which is going to be the most prevalent type of diabetes. And this is, I think, the ICMR data, which shows that about 63% had type 1 diabetes, but in that group, 25% had type 2 diabetes. A more recent data, again coming from Chennai, that shows that if you amongst people in younger age groups, now we have nearly 50% of the people below the age of 40, I think, and have type 2 diabetes. So I think the prevalence is changing quite rapidly as well. You must be very cautious here. I mean, I think with this particular figure of what was quoted here from the Praveen, what they were saying is the proportion of people with type 2 diabetes in a cohort of less than 25 years with diabetes. But I think the newspaper headlines picked up differently. And I think there was one paper in Economic Times or in the Sun Times which said that 25% of all youth have type 2 diabetes, which I think is a slightly wrong representation. So there are some things that emerge, and when you look at the epidemiological patterns, you tend to see some interesting data. And this is from the National Diabetes Audit UK, which I said is published last month. And what you would see here is that there is a definite change in the pattern of the gender distribution of diabetes and type 2 diabetes. As you can see here, between the ages of 19 to 25, 60% of them are women. Okay, and that seems to totally slowly reverse as the age increases. So even under the age of 40, women are slightly more represented. So below the ages of 25, women are most likely to be affected. Between 26 and 39, they are nearly equal, but the gender ratio flips differently from 40 to 59 years. So in other words, there is some seemingly an increased predisposition for women or female gender to have type 2 diabetes in much younger ages. And this may be a factor that maybe we still don't understand why this is the case. There are lots of theories. Maybe because of the changes that happen during puberty and have an impact in female population greater. But it may also be to the fact that a lot of people are diagnosed with diabetes in pregnancy, and they often tend to be women. But nevertheless, this is a very interesting pattern that you see that type 2 diabetes is more common amongst women below the ages of 25. So what predisposes to type 2 diabetes in youth? Now you may wonder what's the difference. I mean, it's exactly the same as type 2 diabetes with the later onset. So if you closely look at it, you already have all these risk factors, and they're all what we identify for classic type 2 diabetes. However, what is important to recognize is that it's not just these risk factors, but it's the way they interact. I mean, it's the clustering of these risk factors. So if in a given person, if you say somebody with later onset diabetes, they may have family history, for instance, and obesity, or they may have fatty liver and obesity, or there are certain patterns that emerge. But in youth, particularly, there is a clustering of these risk factors. So there are more than 3 or 4 risk factors that occur at the same time, and that interaction is what is very worrying, and that's what we will explore a bit more in terms of how these contribute. Now, first, at the top of the list is obesity. Now we can argue as to whether obesity in itself is a risk factor, but there's absolutely no doubt that the prevalence of diabetes which we are seeing, both whether it's younger age groups or older age groups, the obesity is the key driver. So if you actually map the patterns of obesity and type 2 diabetes, you would actually see that they are all linear. So as the obesity rates across the globe have increased, so has the rate of type 2 diabetes. But what's important is to understand is that the relationship between obesity and early onset type 2 diabetes. So basically, in much younger age groups, you can see here that if the age at diagnosis is less than 30, look at how severely obese they are. And in older age groups, the obesity still is a contributor, but they're not as obese as in younger age groups. So in younger age groups, the severe obesity actually is pushing them towards the predisposition to diabetes much harder. And clearly that is undoubtedly one of the most significant drivers. And that's the same whether you actually see in females and males. And here you can see that in type 1, you can see that the dark ones are obese and the gray ones are overweight. Typically, of course, we still have some percentage of overweight and obesity in type 1 diabetes, but in type 2 diabetes, they're hitting almost like 80%. And that is what is worrying. So childhood obesity, and I think you would have to tell me how you're seeing that patterns in India, but at least in the UK, we are seeing a real challenge here in terms of tackling childhood obesity. Nearly about a third of our kids in primary school are obese, and that's a major concern because they continue to go on to develop other problems. But what we need to understand is that obesity is not the sole reason. So it doesn't mean that you cure obesity and everything changes. There is also a defect that has to underlie where the obesity actually can unmask that preliminary defect. And that is because we know that not all obese people will develop diabetes. So ultimately, it is about your pancreatic function on the or your ability to mount a good beta cell response. So in people who have already got a modest beta cell response, if they become obese, then their tendency to diabetes becomes manifest more easily. And there is this data, there's a lot of studies done by Adamo and his team, which actually shows that if they've taken, they looked at the beta cell responses and disposition index. Disposition index is where it measures the insulin capacity against insulin resistance. And what they did was they selected a group of obese people and looked at the people who progressed to diabetes or didn't progress to diabetes. And you can actually see that in people who did not progress, they had a good insulin response, whereas in people who progressed to diabetes, they had diminished insulin response. And same with the disposition index, which actually showed that in people who progressed, they had a much lower disposition index, meaning that they were more vulnerable. So the take-home message is that yes, obesity is an important risk factor and absolutely the #1 risk factor, but it basically unmasks the underlying beta cell dysfunction. So in some ways, this is like a natural test to see who has got the best beta cell function. But moving on from obesity, then there are other things which is interesting is that ethnicity. Now, you may not notice this as a major issue from an Indian context, but for countries like, say, UK, Canada, USA, where we have representation from different ethnic groups, this becomes extremely important as to see why some ethnic groups are disproportionately affected with the same environment. Even, say, people of Indian origin born in the UK would have a higher risk of diabetes compared to, say, a white Caucasian child who was born in the UK at the same time. So you can actually see that in the UK, this is the UK data, if people from, say, South Asian backgrounds and white backgrounds are disproportionately affected. It's almost like if the baseline is 0.35 amongst white, South Asians 1.25, and Black African Caribbean people is 3.9. And the same kind of thing is being noted in studies from United States, where again, they've seen that if people are from a Hispanic background or if they are from an Asian background, quite significantly predisposed to type 2 diabetes. And this is, you can see here. So non-Hispanic whites would be the classic American Caucasian whites. So you can see type 1 diabetes is 94% and type 2 is only 5.5. Look at the Asian cohorts. You see 80% of them have type 2, only 20% have type 1 diabetes. And again, on the right side of this slide, you can see this kind of thing, which is we've got from the National Diabetes Audit in the UK, which again shows that in younger age groups, particularly between, say, 19 to 25 or 25 to 39, below 40 years, 26 to 39, there is the blue one. So, for example, we call them as South Asians, and these are all from Indian, Pakistan, Bangladesh origin. You can see that they are disproportionately represented. The one next to that shows you the percentage of people in that age group who, in the general population, But if you just compare this, so for the population size, the number of people with diabetes is extremely high. So ethnicity seems to give this kind of a predisposition. And why so? Again, it's a very complex thing. I've done lots of work on ethnicity, and I can say that we've still so far not identified any definitive reasons why certain ethnic groups are predisposed, because it's a very complex area. But it's undoubtedly the fact that, let's say, if you're belonging to Indian or South Asian ethnicity, there is a greater chance that you could have diabetes at a much younger age as well. But what is also interesting is the family history. Now, I don't know how many of you take family history when you see patients, but I presume you do. And what you need to understand is that the family history is the single most important predictor of future risk of diabetes. So if there is a family member in, so the closer you are, say first or second degree relative with type 2 diabetes, your chances of getting diabetes is pretty high. Unfortunately, it's not great news, but that's the case. And there are studies which have shown that even if you test for multiple polymorphisms of genes and compare against family history still trumps everything. So it basically is a good indicator. And what you can see is that the more number of family members with diabetes affected in your family, the age of diagnosis, not only that you get diabetes, but the age at which you get diabetes diagnosed also reduces. So for every 10% increase in the number of family members, the age of diagnosis is reduced by 1.7 years. So again, it's a very, very strong predictor. What I would also like to emphasize is that in the family history, maternal history of diabetes is a very, very good predictor of the risk of future diabetes. Certainly, if you look at the studies involving youth with first-degree relatives, 80% have family history and 60% have maternal history of diabetes. Now, I'll come to this in a bit more detail, why this is so important in the next few slides. And this is more evident, again, in certain ethnic groups. So maternal diabetes, I mean, obviously, if you have any first-degree relative, that causes increased risk of diabetes, but maternal diabetes is such an important thing. So, for example, I mean, there is some interesting studies done in Kima Indians by Bellary and his team, and these are in patients who were exposed to maternal diabetes, and when they looked at the children born to the same mother, okay, and they looked at when the mother had diabetes, so pregnancy which was associated with diabetes and pregnancy which was not associated with diabetes. And what they looked at is that if the child was exposed to maternal diabetes whilst they were in the mother's womb, they had a greater risk of getting diabetes when, say, in the early years of their life. So whereas compared to the child born to the same mother when the mother didn't have diabetes, the risk of the child born to the mother who had diabetes is disproportionately high. And that means that there is something in the intrauterine environment that kind of maybe influences say the genetic expression or the way the metabolic programming, let's say, happens in the intrauterine life, and that determines the future risk of diabetes. We need to understand this very important, very carefully, because this is where we might be actually almost just starting a transgenerational cycle. So, for example, a child born to a mother who has diabetes has already got a higher risk of diabetes and developing diabetes early. So, if they become pregnant and they would also have diabetes, which means that the child born to them would then again have diabetes at a much earlier age. So in other words, I mean, we are propagating diabetes through and through. What we might have to therefore focus is about how we manage diabetes during pregnancy, and I think this is extremely important. So when you do have, say, gestational diabetes or type 2 diabetes ladies who become pregnant, it's extremely important that you manage their diabetes well. Of course, I do not have the data to show whether such interventions will reduce the risk of diabetes subsequently. This is something that's subject to future research. But what we need to understand is that the mother's health has an important implication on the child to be born. And therefore, we need to actually focus a lot on that. And remember, both maternal undernutrition and overnutrition can contribute this. And I think Professor Yajnik from Pune has done a lot of studies looking at undernourished Indian women, and he has shown that that almost sets in a metabolic programming which predisposes children to have diabetes. And we in the UK and in studies in Sweden and other places, we have seen that over nutrition of mothers during pregnancy can also have a deleterious impact. So both undernutrition and overnutrition can have an impact. But again, coming back to the point, maternal diabetes is extremely important. What about socioeconomic status? Well, all health outcomes, as we know, are linked to socioeconomic status. So if as a physician, you need to determine one single factor that determines the health of a population, that is socioeconomic status, no matter what. I mean, you can say that it's cardiovascular disease or stroke or cancer. The socioeconomic status is the most important predictor of health outcomes. And clearly, if you are looking at the strata which have, say, low socioeconomic status, then they are predisposed to most adverse health outcomes, and diabetes is no exception. And again, this is data from National Diabetes Audits, which in the UK, where we are seeing extremely high levels of interaction between, say, socioeconomic status and diabetes. And in some instances, there is the interaction between minority ethnic groups, socioeconomic status, obesity, and type 2 diabetes. Remember the clustering of the risk factors, which I mentioned, that is seen most evidently in people with low socioeconomic status. So again, we can't, I mean, the challenge is how do we make everybody rich enough to have health outcomes, and that's a bigger challenge in countries like India, where we have huge disparities. But again, when you are seeing people from low socioeconomic status, just be mindful that they may be more likely to have these kind of health issues. And we did some studies in the UK. My team, we tried to characterize these patients. Obviously, we have lots of them, but because when you do a scientific study, we are limited into the numbers, and we had to focus on a small cohort of patients. And basically, what we did see was that there were features. One of the things that emerges is the BMI. It's 32. I think you may not see so much of that in India, but we do have obesity quite prominent in South Asians as well. But remember, the South Asians were less obese than white Europeans. But what is interesting is the muscle mass. So if you compare the muscle mass between white Europeans and South Asians, there is a significant difference, statistically significant difference. So for some reason, our lean body mass is less compared to the similarly aged white Europeans. Now, this may be genetic, this may be environmental, this may be the fact that we don't exercise enough. But if you have less lean body mass, then again, that would predispose to diabetes as well. But again, look at the maternal diabetes rates. If you look at the family history, 92% of South Asians had family history of diabetes. Maternal history, 70%. So mother having diabetes is almost a predictable thing. We do see other features like acanthosis or PCOS. Again, those do contribute immensely to the risk factors as well. And if you look at the evidence from the Today cohort, which is from the United States, again, you can see similar patterns. So if you look at the household incomes, again, you can see that 40% of them had low income. And again, preponderance of the female sex, which is about 65% of these people were female. And clearly that is indicating that females from certain ethnic groups have the highest risk of getting diabetes as well. And this is the clustering of risk factors, which I said, and this is just from the Today study. But if you also look at from the study which we published, we've seen that about I think 75% of all our subjects had more than 3 or above risk factors, and that kind of clustering is very important. So just by noticing that if you are from, say, South Asian ethnicity, which is, again, as I said, India, Pakistan, Bangladesh, Sri Lanka, and so on, if you are a female aged under the age of 25, and from a low socioeconomic background, that puts you at nearly 70% risk of having type 2 diabetes at a younger age. So what are the distinctive features of type 2 diabetes in youth? First thing to remember is that it has an aggressive phenotype, and there is a rapid decline in beta cell function. And they've also got disproportionately higher rates of complications. So if you look at the decline in beta cell function, so there are studies which have been done with using insulin hyperglycemic clamps, and you can actually see that if you look at the classical decline in beta function in older adults, it happens about 7% per year. Whereas in those developing diabetes in adolescents or early youth, there is a 15 to 20% per year decline in beta cell function. So there's a much faster decline in beta cell function. Again, we don't know what causes this, but we do know that this is a phenomenon, and therefore the diabetes tends to be more aggressive. And this is also demonstrated in the more clinical trial scenarios, where we can actually see that, say, in the loss of glycemic durability. There's a 2-day study which was done in the United States in adolescents and children, and they compared metformin lifestyle and metformin plus rosiglitazone. So if you look at the metformin alone as well, I mean, there was a lot of people failed therapies, so did the people with lifestyle, and that tends to be lost much quicker compared to, say, in older people, where there's a much slower loss of beta cell function. And therefore, we also see that many of these patients would require insulin very much earlier than you would see in older adults. So within, say, less than 4 years from diagnosis, I think if you look at our data, we showed that there was a significantly less, say, C-peptide response. But between 5 and 9 years of diabetes, basically that declined much more rapidly. Okay, 53% of our subjects were on insulin treatment. 60% started treatment with insulin in the first 3 years, and at 6 years of diagnosis, that increased to about 72%. So again, it's suggesting a very aggressive phenotype of type 2 diabetes. What about rates of complications? So the only data we have on this is from the SEARCH study, which is done in the United States, which actually looked at younger adults with diabetes, and they compared both type 1 and type 2 diabetes. So, for example, I mean, they had data from about 1,700 type 1 patients and 270 type 2 patients. Remember, the mean age is only 17 or 18 years. Okay, and type 2 diabetes, they had only about 8 years duration. So it's not that they have been having diabetes for 30 years. But look at the prevalence of complications. If you have type 2 diabetes at a younger age, look at the kidney disease, 20% versus 5% in type 1. Eye disease, 9% versus 5%. Nerve disease, 17% versus 8%. Cardiovascular disease as well. Arterial stiffness, nearly 50% of people with type 2 diabetes having arterial stiffness. So not only you're getting diabetes early, but if you think that at the same age, people with type 1 diabetes also are at risk, your risk with type 2 diabetes is much greater, and they develop complications just in a matter of decade, and they can be quite severe as well. And there's lots of other studies which show similar kind of patterns compared to type 1 diabetes. Again, increased risk of nephropathy, increased risk of retinopathy, increased risk of all complications, suggesting that it's a very aggressive form of type 2 diabetes. And again, if you look at the proportion of patients with, say, in our study, which is looking at the complications, over a third of our patients had microvascular disease, and they were slightly higher in South Asians. So, and 2/3 of the patients had 2 or more established cardiovascular risk factors. Now, remember, below the age of 40, generally we don't tend to use statins. At least that's the general pattern of practice in UK and other places. but they already have cardiovascular risk factors, 2/3 of the patients. So the risk of getting, say, MI or a stroke increases disproportionately between the ages of 45 to 50 years. So again, we hear stories of people dropping down dead because they've already been exposed to high cardiovascular risk for nearly 10, 15 years because of diabetes. And of course, one of the things which we wanted to look was, this is another data from a study which we looked at, it is we wanted to see if, because of the changes in beta cell function, whether the progression is quicker from pre-diabetes to diabetes. Now, this was a population-based study, it was a prospective study, but what we did find was that the age of onset of pre-diabetes did not predict quicker progression to type 2 diabetes. However, what we did find is that the people from certain ethnicities, and if you are from deprived backgrounds, then they tend to be having a greater predisposition to progress much faster from pre-diabetes to diabetes. So again, that tends to be a factor in how the ethnic predisposition tends to work. What about management? If you look at the randomized clinical trial data, there's very little evidence so far. That's because we haven't got enough number of people to do large trials. And if you look at large randomized controlled trials, especially between 18 to 40, they're poorly represented. However, we can take it as a matter of principle that if somebody is above the age of 18, we can treat them as per the guidelines applying to the adults. But if it is below 18, then the therapeutic options, to some extent, evidence-based therapeutic options are limited. So you can try total diet replacement, and this was done by a group in Qatar, where they actually, just like direct study, they basically used a very low-calorie diet in youth with type 2 diabetes, although the age was 18 to 50 years. But they demonstrated that 61% of the participants in the intervention group had diabetes remission. So clearly, calorie restriction, weight loss can help in early stages to try and reverse diabetes. And this is less than 3 years. I know, just speaking to Anita, she was saying Practo do a lot of diabetes remission things. So this may be more applicable in youth as well. What about new therapies? Well, there is, again, as I said, there's not much evidence, but there is some promise, particularly if you think about SGLT2 inhibitors and GLP-1 agonists, because of the effects they have on weight as such, and because of the non-insulin pathways of glucose disposal, some of the benefits can be accrued in these groups as well. So there may be drugs that may have some promise. And certainly, there are a couple of studies which have been done in pediatric age groups. This is with liraglutide. Again, only 134 children randomized to liraglutide plus metformin or placebo for metformin. And at 26 weeks, there was a significant reduction in the liraglutide group compared to placebo group. So this was one of the first studies that is done. Otherwise, there have been limitations in what you can offer in adolescent age groups. And subsequently, more recently, we had this paper which tested dulaglutide in youth onset type 2 diabetes. Again, patients who received dulaglutide, 0.75 and 1.5 milligrams, actually had a much greater reductions in HbA1c, which is about, say, 1.1 millimoles of change in the glucose on average. And the HbA1c again decreased about, say, 51% of the people who were on dulaglutide were achieving less than 7% HbA1c targets compared to those with placebo. So again, this gives us some kind of reassurance that perhaps GLP-1 agonists could be tried in children or below the age of 18 with type 2 diabetes with some confidence. But more studies are clearly needed at present. Again, once-weekly injections of semaglutide have also been shown to have some effect. And as you can see, I mean, they not only lose weight, but this is basically in obese adolescents and looking at the changes in weight. And the semaglutide effects seem to persist in these participants as well. So a very encouraging trend for people with, treating with GLP-1 agonists in a sense. Well, one of the things that works, we know, is bariatric surgery. And there's a study which was done as called as a teen lab study published in the New England Journal, which looked at the sleeve and gastric bypass and its effect on diabetes remission in adolescents with type 2 diabetes. And basically, what you can see here, I think here you can see the type 2 diabetes. And if we can look at the prevalence here, and at 3 years, they can see that there is a significant remission of about 94% with gastric bypass, and significant remission of even pre-diabetes as well. So bariatric surgery does work, but you must understand that if you are subjecting somebody below the age of, say, 18 years to bariatric surgery, and that can be quite hard. So I think, personally, I think we need to be very cautious in recommending bariatric surgery in much younger age groups. But what it demonstrates is that if you do achieve the 30% weight loss, and that is a challenge, but if you can achieve 30% weight loss, you can see about 90% remission in diabetes. So that's again the link between obesity and diabetes that seems to come back again and again. But the challenge, of course, is to say achieving that degree of weight loss by any means. And if you are able to do that, then we can see significant changes in risk and also likelihood of remission of diabetes. So, but there are lots of questions that we don't know answers to. We still do not understand the pathogenesis and natural history. And we did a review in the Lancet around this topic about 4 or 5 years ago, where we identified lots of things. And I know there was been a subsequent review again in the Lancet by one of my colleagues in London, which highlights some of the gaps in knowledge. And we certainly need better understanding about the therapeutic choices we have, and how we're going to treat these patients. Because if they are going to be put on sulfonylureas and insulin, we are only going to make their obesity worse. But there has to be caution in using other medications as well. Remember, a lot of these people are likely to get, if they are women, more likely to plan a family. So some of the drugs like GLP-1s cannot be used in pregnancy, which is a hindrance. And we need more research in diagnosing and screening, and especially differentiating type 1 and type 2 diabetes, which can be a considerable challenge in these age groups, and how we support them in terms of transition services. And of course, we need a collaborative approach between clinicians and researchers, because these patients are scattered everywhere. They do not come in one particular group. So unless we are able to identify them early and then undertake proper research, we are still going to be in the dark in terms of what we know about this condition. So in summary, please remember that type 2 diabetes in youth is increasing in prevalence and is characterized by a very aggressive phenotype, by rapid decline in beta cell function and increased propensity to complications. Please remember that when you see clustering of risk factors, I think that should prompt you to screen for possible type 2 diabetes, particularly in obese people, and especially if they've got a maternal history of diabetes. And effective management requires an integrated and collaborative approach. This might even require, say, a dietitian and a psychologist, for example, because the age group is quite a complex one and needs a lot of support. I know I may have tried to fit in everything here, so if you still have any questions after this talk, I'm more than happy for you to contact me, and that's my email. And I think this would be available. The slides would be shared, so I'm more than happy for you to ask me questions now or a bit later as well. So with that, I'd like to stop here, and I'd like to see if you have any questions I can answer. Thank you.
Thank you, Dr. Bellary, for this amazing and informative session. The data look a little scary. Actually, I was shocked to see the percentage of this rapid decline in the beta cell this function compared to the elder diabetics. It looks a little alarming. So we will take questions from the audience. So we have one question here from Dr. Nalanda Devnath. What
Mhm.
percentage of the women with gestational diabetes develop type 2 diabetes, and in how many, approximately, how many years?
So what percentage of women with that?
With type 2 diabetes, with what percentage of the women with gestational diabetes develop type 2 diabetes?
Okay. I think the data is so gestational diabetes is clearly a risk factor for future diabetes. It depends upon how you look at the risk within a span of time. So, for example, if you look at, say, within the first 5 years, they have, as far as I remember, about 3 to 4 times greater risk than the general population to develop diabetes within the first 5 years, and certainly that increases considerably, say, in the next 10 years. The exact numbers, I don't know, but it's about 3 to 4 times the greater risk. So if you have somebody with gestational diabetes, ideally, they should have an annual HbA1c check, because the risk of getting diabetes is about 3 to 4 times greater than people who do not have gestational diabetes.
Thank you, sir. Thank you for this explanation. We'll wait for a few more questions from the audience. And meanwhile, I have a few questions, sir. So my first question is around the ethnicity and the youth onset diabetes. You showed us beautifully how there are ethnic differences in the prevalence of the youth onset diabetes, and how ethnic minorities have higher prevalence of type 2 diabetes in young. I would like to ask you, is there any data on ethnic differences in the outcomes of the youth onset diabetes in terms of mortality or cardiovascular complications or any other complication? Do they differ with ethnicity as well?
Yeah, I mean, in terms of the younger population, we still haven't got the data, because I think not many people are collecting that. But invariably, what we do see is that if you are exposed to risk factors much earlier, and if that's the way the ethnic groups are exposed, then the risk of complications do increase substantially as well. We see that in older onset type 2 diabetes. So for example, if you look at Asian populations with type 2 diabetes in the UK and compare them with white, there is a higher risk of microvascular complications and macrovascular complications. Both the outcomes are worse. What we also, on a positive note, however, what we have seen is in the last, say, 10, 15 years, there's been an increasing awareness, and we have been aggressively treating these risk factors. So even though the risk is higher, the risk seems to be coming disproportionately from the risk factors. So if you control the risk factors better, you can actually reduce that risk substantially. So what we are now seeing is that by better control of blood pressure or cholesterol or even HbA1c, we are narrowing the gap between ethnic groups. So yeah, by itself, ethnicity adds as an independent risk factor. There is a risk, but that's minimum. What is greater is the severity of risk factors. So what I would like you to do is to focus on the risk factors. But certainly, if you don't control risk factors, the outcomes are really bad.
Thank you, sir. Thank you for this comprehensive explanation. Any other questions from the audience? Please put up your questions. So by the time we are getting questions from the audience, sir, I would like to ask you one more question. One recurring theme in your presentation was that obesity in the youth onset diabetes. But as you know, especially in the Indian subcontinent, we have so many lean diabetics. They have their challenges in the management also. Like, it's a little difficult compared to the obese diabetics. So my question is there any data on the youth onset diabetes in the lean people? Like, could you explain more about this?
Yeah, I mean, see, that's a very, very interesting point. So I think what we tend to see is that we associate diabetes predominantly with obesity, but lean diabetes is extremely an interesting cohort of patients. Certainly, I do have. There are two explanations, two things. People have theories, because we haven't really done very conclusive scientific studies in lean and versus obese people. Now, the first theory that's argued is that even though our populations look lean, if you look at the actual body composition, they still have lots of visceral fat, and that is not apparent because there are lots of, I'm sure you would have seen in lots of presentations, Professor Yajnik, and there's a professor from London, very famous photograph showing the same BMI, but the body fat distribution is very different. So when we just visually see them, we cannot appreciate that, but there is certainly more visceral fat, which predisposes to diabetes. That's one theory. But the second theory is that what we think is that, see, inherently in a population, there are people with less beta cell capacity, and there are people who have really robust beta cell capacity. So if you actually look at that as a graph, you can see that if you have really robust beta cells, you can be quite significantly obese and still not get diabetes. And we see that. We see that in people with BMIs of about 58, 60, no diabetes. And you have people with a BMI of 26 having diabetes. It's so unfair, but the reality is, what it actually shows you is that obesity, as I explained to you, unmasks the underlying beta cell function. Okay, so if you are getting diabetes at a much lower BMI, what it actually means is that your beta cell response is not adequate. So there's something not right with the beta cell. So they're not classic type 1 because you're not seeing the autoimmune destruction of islets. But for some reason, their beta cell response is not adequate, or they're highly insulin resistant, either of these two. The only way to say that is by doing some clear insulin or, say, clamp studies to see how much difference there is. But certainly, that's what it is. So obesity unmasks the underlying beta cell defect. That's why we see that in people who've got low BMIs still getting diabetes, and that invariably means that they have low beta cell response. Therefore, they may need insulin much earlier. And I think that's the thing to remember. Similar is the case of pregnancy. Pregnancy is a test. It's a natural test. So not all women who become pregnant have diabetes, but some do, some don't. Why? That's because inherently, again, you have to have a good beta cell response. So all these are, and same with the steroids. If you give somebody like a high dose, 40 milligrams of prednisolone, some people will get fluctuations in blood sugar, others maintain it very well. So these are all like stress tests naturally occurring, which unmask the underlying beta cell deficiency. So the lean type 2 diabetes, coming back to your point, is a very interesting group. Very little research has been done, but we are seeing, even in our national diabetes audits in the UK, amongst all those youth which I've described, about 10 to 15% are lean with a BMI of less than 25. We haven't studied them, but that's one of the groups that we would like to study.
Okay, so thank you, Sarik, for explaining this. So any further questions from audience, anybody? So, so my final question, one more I have for you. This is a little practical one. So, in United Kingdom, where you stay, so there are many like government-run diabetic programs, like National Diabetes Prevention Program or National Diabetes Remission Program, that are running successfully. Do you think now time has come to start similar programs even for the youth, those who have type 2 diabetes? Because I feel they are at a very high risk. The data looks very alarming, and it's very aggressive form of disease. So do you know any such programs around the world, like for the young diabetics type 2?
So in the UK, we have a very, very good the National Diabetes Prevention Program, and also the National Diabetes Remission Program, following on from DIRECT. Previously, it was offered for people above 40, but that age has come down to 25 to 40 now. So we are looking at that age groups. Below the age of 25, particularly in the pediatric age groups, it's still not done as a national program, but it's done through referral to secondary care centers where we've got specialist pediatricians managing. So that's, and I know that in the United States, in the today's trial, I mean, they're trying different things, including lifestyle changes and so on. But the trouble we have is that for us to do anything substantial and show you the evidence, we need large numbers of people, and especially if you want to go for prevention trials, the numbers needed to get any statistical significance is quite huge, and we haven't got those many numbers. That's a problem. But there is a recognition now that, especially in the ethnic minorities in the UK, 25 is pretty much a age where we start offering these. So we are offering both diabetes remission and diabetes prevention programs. So for people with, say, we call this as non-diabetic hyperglycemia, they're going to the prevention program. People who already have type 2 diabetes, they're going into the remission program that's being offered. Unfortunately, the uptake has not been great. So not many people want that because it means that you are on a liquid diet for 3 months and they don't really like it. But that's happening, and some data is just about emerging from those.
Okay. Thank you, sir. Thank you for this explanation. So any further questions from the audience, fellow doctors? If no questions, then we'll conclude this session. Anybody? Okay. Thank you, sir. Thank you,
Right.
Dr. Bellary, for this
Yeah.
amazing and informative session,
Right.
sir. Thanks a lot. I'm sure the doctors learned many things from you. Yes, sir. So I think I would like to thank you, sir, first of all, for taking out time for this session. And I would like to thank our fellow doctors also who joined us. Thank you, everyone, for joining.
And
thank you very much.
Thank you, Anita, and thank you, Vidya, and all the doctors who joined. It's been a pleasure, and I wish you a very good weekend. Bye-bye.
Sir. Bye, sir. Thanks.